Welcome. We are at about 4 minutes after the hour, so I am going to get us started. Please introduce yourself in the chat with your name, organization, and where you are joining from. Today, we are using Wordly AI translation. You will see a QR code on the screen. You may scan that code with your phone, join the session, and choose your language. If you prefer to read the translation on your computer, you will see a link in the chat to join the translation session. You may also listen on your computer. Everyone during this forum should sign into Wordly AI translation, as one of our speakers, Dr. Nicolas, will speak in French. So everyone should enable the Wordly translation from the QR code on the screen or the link in the chat. I'm excited to dive into our rich topic for the next hour and 15 minutes or so, keeping faith-based community health programs sustainable through change, and to hear from our highly experienced speakers. First, first, let us set our minds to hear from God with a prayer. Please pray with me. Father, Lord of creation and transformation, thank you for bringing us together today to discuss and learn from examples of sustainable development. May we, like Nehemiah and Christ, assess, mobilize, support each individual's skills, facilitate working together, and equip to withstand through opposition, so the people may declare, "Let us rebuild," work with all their heart, and grow into communities that love one another and into cities on hills that cannot be hidden. This I pray in the name of your Son, the greatest sustainable transformational developer, Jesus Christ. Amen. Again, thank you for joining us, and please introduce yourself in the chat. Uh, Here you can see my name is Laura Smelter and a bit about me. My email and nonprofit website are in the chat. I'd like to thank CCIH for inviting me to moderate this session. It's an honor. I have tried throughout my career to approach local and global health work with a community development mindset, and I'm eager to learn from our esteemed speakers. As this is a members forum to promote interaction and gauge learning, we are starting with a short poll that we will repeat again at the end of the forum to see how everyone is feeling. Our goal is to help you feel more comfortable in your knowledge of community-based programs. Thank you for participating. You should see the poll on your screen. Oh, wow. Okay, so it looks like most people feel they have moderate knowledge of community-based health programs. Some good, some very good, and some limited and very limited. So I'm excited to see if how this changes by the end of our forum today. Thank you all for your answers. To introduce our topic, as I mentioned, I have tried to approach local and global health work with a community development mindset. Even in unlikely settings, from building a hospital in Honduras to revitalizing a hospital in Nigeria to responding to a hurricane in Haiti, I have seen the powerful transformation that can happen when we place the people and the community at the center of our efforts. And we all want those efforts to have positive, long-lasting impact, even continuing after initial funding or external support has ended. A beneficial, sustainable program can encourage future development and transformation. When I worked in Haiti in 2010 after the earthquake, we initially set up community clinics as part of disaster response efforts. As things stabilized, the communities themselves asked for capacity building, and when we left, they kept those new clinics running and serving their communities. When I worked in Nigeria, a young family from a cousin religion sought care at the hospital, saw the unity of the Christian healthcare workers and community rebuilding the hospital, and invited our chaplains to visit their village. Sometimes sustainable community development can be physical, sometimes spiritual, and we pray most times both. With that brief introduction, we've reached the moment that we've been waiting for. Let's hear from our speakers. Dr. Charsey Cherry is the Community Systems Strengthening Advisor at Global Health Action in Atlanta, Georgia, United States. He joined Global Health Action in 2022 with more than 30 years of public health in his career working with community partners in the US, India, and parts of Africa, and with the National Institutes of Health. He currently works with Global Health Action's Ripple Effect program, East Africa Network. A fun fact Charsey shared with me is that he loves jazz music and in the last few years learned to play the saxophone. I would love to hear him play and am eager to hear what he has to share with us today. Dr. Charsey.
Thank you, Laura, and thank you for the opportunity to be here, CCIH. So Global Health Action has been working in low-resource communities in the Global South for 54 years, providing capacity building training to organizations and leaders that aims to foster transformation through leadership and governance, organizational development, network development, community program interventions, data collection, and advocacy. Now, GHA's Ripple Effect program currently works with 8 implementing partner CBO/NGOs in Kenya, focusing on addressing local health priorities benefiting women, children, and adolescents. The program combines health system strengthening and community system strengthening. Now, personally, I've been working with community-based and faith-based organizations doing public health related work for more than 30 years in both the US and parts of Africa. Engaging in community-based and faith-based work is challenging because this is social justice work. And oftentimes we find that the powers that be are not interested in social justice work. However, as challenging as it can be, it is also rewarding, especially when community programs are sustainable and community-based organization members are motivated even through changing times. So I'd like to share 5 things that I've learned that I feel are key to helping community programs remain sustainable and community organization members stay motivated. First, sustainability is fostered through local ownership, which is really equal to community ownership. Communities and community-based organizations know how to solve their problems. They want and need to own their programs. They need partners, not parents. We support them, we co-develop, we co-create. However, they own the program. And when they do, they work hard to sustain the program and members remain motivated and committed to the success of the program. Number 2, community-based organizations need strong organizational systems. They need strong management systems, operational systems, information systems, data collection and monitoring systems, and reporting systems. When strong organizational systems are in place, the organization and programs have the capacity to grow and expand. Thus, there's motivation within the organization to sustain, grow, and expand the programs. Number three, ongoing community engagement. Communication is the key to all relationships, and community-based and faith-based organizations have a relationship with the community members. They foster this relationship through ongoing engagement. They have to provide feedback to the community and receive input from the community about the program, and this engagement process can help programs remain sustainable and motivation remain high within the organization. Number four, prepare for change and respond quickly. Change is inevitable, whether it's internal or external, planned or unplanned. Changes happen in personnel, in technology, in funding, the environment, the political landscape. The best thing that community-based organizations can do is expect it and prepare for it. However, even when it comes unexpectedly, we have to respond to it quickly. We have to pivot. We have to be ready to adapt, adopt, and find the positive in the change. And then finally, celebrate the wins. There always will be setbacks, pitfalls, problems, but we can't get bogged down in those. Small wins happen around every day, all around us. And when community organization members take the time to embrace and celebrate the small wins, they can be a driving force to help sustain programs and motivate organization members to keep thriving. Thank you very much.
Thank you, Dr. Charsey. Those were awesome points. Very helpful. On, I can't see if Dr. Nicolas is here. So we will come back to and save French for last. Reverend Troy. Sorry, I lost my
Hello.
place.
I'm sorry, go ahead. I didn't hear you. Let me turn this up here.
Okay. Reverend Troy is co-founder and
Okay, you said
executive
go ahead
director.
on. Oh, go ahead. I'm sorry. I'll stop.
Oh, yeah, let me introduce you, our esteemed speaker. Reverend Troy Lewis is co-founder and executive director of Expanded Church Response in Zambia. Since relocating to Zambia in 2002, he has mobilized churches and communities to respond to HIV/AIDS and related causes of suffering with compassion and practical action. Under his leadership, Expanded Church Resources has expanded to address broader health concerns, including gender-based violence, family and community strengthening, economic transformation, and crisis response. He is committed to elevating the leadership, experience, and lessons of African churches and communities as vital contributors to locally led, faith-rooted transformational development. I'm excited to hear from you, Dr. Troy. Reverend Troy, sorry.
Okay. No, good morning. My name is Troy Lewis. I think thank you for the introduction. And what happens is that I think what I want to look at today is that is looking at this from a perspective of micro and a macro perspective as it relates to community sustainability that we're discussing here. Part of it, I guess, with regards to the micro aspect of it is that more so looking at the aspect of in community and what we're doing, engaging at the grassroots level. And then macro are some of those aspects of interventions that we have to see about engaging with that's going to impact that. And so I'll be sharing both of those today in this time that we have here. And so a little bit, I guess, in terms about ourselves, I guess, looking at my own introduction. We've been working with about 80 community faith-based partners. Particularly that was especially during our last project that was particularly funded by USG and USAID, may they rest in peace. And I won't get into some of those things right there. But 80 community faith-based organization partners we work with to build up where there's capacity. And that's been one of the pieces that have come out of this whole thing there, that the capacity that's been built on the ground here, that I think that I'll be talking about to serve us in this aspect of sustainability. And out of those, with those 80 we worked with, we trained up and worked with, built a capacity of 7,000 community-based care workers, a largely volunteer workforce, and then we'll talk about how we augment that. But large outer churches, larger faith-based and largely faith-based community groups that we work with. We built a capacity integrating the work with local clinics, case finding, case management. As we talk about is looking at these different levels here, part of what we're looking at here as it relates to community organizations is about that what we did built into our project at that time, looking at sustainability, was that looking at building, looking at for these while they were volunteers and we couldn't afford to pay them, what we looked at for sustainability as it relates to income for those that are on the ground is seeing about training. And I think any of the variety of projects, I think many of you are looking at from community savings groups. As we looked at those working with those community savings groups, that helped those who were healthcare workers that were volunteering to be able to support themselves and with a sustainable and a growing income and those institutions, how to seeing about working with and doing those community savings groups to work with those members that were in the community. And from community savings groups, our model was with regards to business training out of those community savings groups. And then from the business training, where we're looking at moving next to, but we haven't had a chance to fully implement, to go to that, looking at working with cooperatives, where they're getting more into farming and animal husbandry and those types of things like that in community and community levels, depending on whether they're rural, peri-urban, or what have you, to seeing about sustainability of these. Talk to, training these in community groups and grant writing and those type of things and seeing about sourcing and resourcing their own funding. And we've had a number of those that have been quite successful in doing that. The other part for sustainability that was critical to us and that we're seeing about taking advantage of is about working with the church faith-based groups. And as it relates to the faith-based groups, they have the networks, the presence, the trust in communities there to seeing about and carrying that on, and they're not working according to project life cycles. So that's part of what we did. So that's working in some ways at the micro level. But the other part of working with the micro level is not just these skills, but as it relates to what we call working with faith-based, these initiatives that we're talking about doing as it relates to health. We've come a long ways in HIV and AIDS as it relates to with the church, that in many ways we're propagating stigma, discrimination, judging as it relates to those who are HIV positive. And we deal with a lot more than HIV, all types of health issues. But as it relates to that, we saw this great story take place as it relates to how the church changed in that response, to seeing about a response there that many people look at and, that many partners and even international entities look back and saying that the church was faith-based, was an indispensable partner in turning around HIV and AIDS. And part of what that was doing and that we're looking at doing now is seeing about instilling in the church and awakening in the church that responsibility that we have for holistic ministry, engaging in healthcare, caring for one another, loving our neighbor as we love ourselves, and those types of principles there. That has been something there that we've been looking at and working with in community levels, to seeing about awakening the potential of the church and the people in the churches. So, for example, there's some principles that we brought to this, that out of this, where we saw this blossoming with us and other places, that out of people's pain, out of their pain, there comes a passion and a sense of purpose. And those are some things that we brought together, that the people brought to these areas here, that not working in project life cycles, but that became part of the DNA of the church in doing this and making this type of difference on the ground. Some of the things that we're doing at a macro level, and I know my time is almost up here, at a macro level, is seeing about getting this story out. And as we get this story out to other places about this awakening of the church in Africa from this transition that I was just mentioning about before, and changing and strengthening healthcare systems, and getting this story out about this awakening that took place through the church from that transition that I talked about. And then one of the things I want to see about doing in the West is presenting the church, and for those who will be donors and those who may be to help in some other places, presenting this work of the church of caring for one another, in contrast to some of the type versions of Christianity that we see there that are looking at me, and myself, and I, and my own interests, my own power, my own wealth, versus the contrast with the success stories that we've seen with the church in Africa. To seeing about getting attention to this, that what we've been doing, that story needs to be gotten out. So that's one of the pieces that we're working with there, as it relates to getting those stories out. to work. One is to encourage the people on the ground there that they've done something that they've been successful. Now let's do it again as it relates to and continue on with this, with these sustainable solutions that we, as we overcome HIV and AIDS, and not overcome it, but in terms of turn around and gaining epidemic control, we can do this and we can do this ourselves here and instilling some of that in them. That mindset change and awakening those biblical theology and those type of things we're working on now, closing now, to seeing about bringing this type of change there. And we've been seeing an awakening of the people that they have a mind to work and they are continuing to have a mind to work and gaining resources from the outside, but also internally, how they can resource this type of work. Thank you very much.
Thank you, Reverend Troy. That was quite
Les dons MSC, c'est un service de santé de l'Église du Christ au Congo, au Sud-Kivu, qui est l'encadreur de 11 congrégations protestantes. Nous encadrons plus de 300 établissements de soins de santé dans la province. Et ces dernières ont différents niveaux ou paquets de soins. Il y a les paquets minimum et les paquets complémentaires. Alors, au niveau communautaire, l'Église du Christ au Congo avec la communauté ou bien la population s'engage dans l'amélioration de la santé maternelle et infantile comme les premières actions, lutter contre la mortalité de la mère et de l'enfant. Il est aussi qui est suivi de la lutte de la disponibilité du sang au niveau des hôpitaux pour, bien sûr, prévenir ces décès maternels. Vous pouvez passer au dia suivant. Next slide.
Next slide.
Yes. Oui. Mais les deux actions pour lutter contre la mortalité maternelle et infantile, nous savons qu'il y a des activités qu'il faut mener, par exemple, comme nous disons, des consultations des prénatales, donc des femmes enceintes, des suivis de grossesse avant la naissance, les accouchements. Il y a aussi les consultations des enfants de 0 à 5 ans pour la lutte contre la mortalité de l'enfant. Ces activités-là sont appuyées par les églises avec des sensibilisations. Pour dire, les leaders des églises sont mobilisés pour parler, pour encourager la population à utiliser les services de santé qui sont disponibles, à ne pas rester à la maison parce qu'il y a des situations où les femmes étant enceinte, il reste à la maison jusqu'au moment de l'accouchement. D'autres restent à la maison, ils n'amènent pas des enfants à l'hôpital à temps pour différentes raisons. Ça fait que on enregistre des cas de décès et des mamans, et des femmes et des enfants. Alors, le rôle de l'Église, c'est cela. Mais aussi, au niveau de la communauté, la population est sensibilisée pour créer ce que nous appelons des clubs de donneurs bénévoles de sang. Ce sont des bénévoles qui donnent leur sang pour appuyer les actions de santé en donnant la vie. Ce que nous mettons ensemble pour que nous sauvions les vies des gens. Mais aussi, au-delà de tout cela, ce que nous appelons le renforcement des capacités, de formation et des prestataires de soins pour qu'ils utilisent à bon escient toutes les ressources qui sont à leur disponibilité, mais aussi bien prendre en charge les malades. Il y a aussi la formation même de ces donneurs bénévoles, les formateurs, des pasteurs pour leur donner plus de connaissances pour bien faire la sensibilisation. Le dia suivant, next slide. Next slide, please. OK. Alors, next slide, parce que je venais de parler de ceci. Merci. Mais tout cela, on est toujours buté aux problèmes qui sont des mouvements de la population, par exemple des prestataires de soins qui quittent des zones surtout rurales vers les zones urbaines pour des raisons soit de sécurité ou insécurité, le problème de motivation financière, il y a ça. Les mêmes personnes qui donnent leur sang, les bénévoles là, connaissent le même problème des mouvements de la population. Je veux vous rappeler que nous sommes vraiment dans une zone avec beaucoup de problèmes, de conflits, de guerres. La population est en mouvement à tout moment et cela perturbe considérablement les activités. Bon, par rapport à la conservation du sang, un défi de conditions. Souvent, nous avons des matériels de conservation, mais la perturbation à l'énergie, on ne sait pas avoir longtemps de l'énergie électrique. On n'a pas en permanence et ça fait que le sang collecté, il est perdu, il est détruit parce qu'il n'a pas été bien conservé. On n'a pas assez de matériel de bonne qualité photovoltaïque pour garantir la disponibilité, pour garantir la bonne conservation. Mais aussi, bon, il y a beaucoup de besoins pour cela, mais les ressources sont très limitées, financières surtout et matérielles. Ça fait que pour y arriver, nous connaissons assez de difficultés. Ce sont des défis là auxquels nous faisons face et nous ne cessons de le dire. Il y a maintenant aussi des problèmes, des épidémies qui sont qui sont en train de surgir à tout moment. Ça perturbe et on ne sait pas comment s'y prendre. Je vous remercie.
Merci, Joseph.
Je, je pense que c'est la fin. Oui, merci.
Thank you, Joseph. Thank you for both Joseph and Dr. Nicholas for your teamwork, and everyone else for your flexibility with the technical difficulties and um, challenges that we have had. But I think that we've heard from a variety with breadth and depth of speakers. And now it's our turn to discuss and ask questions and discuss amongst ourselves. Some of the themes that I heard throughout the speakers was the importance of community ownership, engagement, and awareness. That all of these programs and efforts that we are making need partners, some church partners, some healthcare partners, community partners. But I liked what Charsey said, partners, not parents, that we are partners, not parents. Other themes that I heard are the benefit of volunteers and capacity building and training, the need for capacity building and training. And the two last themes that I kind of pulled out that many of the speakers mentioned were to find the positive in the changes and challenges. They mentioned some changes and challenges, and we have some questions for all of you on those, on changes and challenges that you're facing. But I'd like us to reflect on how we can find the positive in those changes also. And then finally, getting the story out, which we'll have an invitation for you at the end of the session today to help with getting the story out. So with kind of those themes in mind and the things that our speakers shared, I would invite us to post your questions or comments in the chat, and we can direct them questions to speakers, and we can discuss amongst ourselves in this member forum. Thank you all for being here.
You can also feel free to come off mute and ask questions. I think we can stop the screen share. Thank you.
Some of the questions that I thought of for our speakers were, what is the biggest pressure your community-based programs are facing right now? If one of the speakers, let me ask Reverend Troy, what is one of the biggest pressures your community-based program is facing right now?
No, thank you. There are any number of challenges. I think what's happening, for example, we have some of the donor funds. Some of the funding, while we had volunteers that would supply the bricks, I would say the bricks for the work that's getting done. Some of the parts of the connected pieces of it, like what I call the mortar that connects it all together, where we're lacking in, such as being able to convene, different meetings and communication. Some of the training, ability to get to out to those areas and visit, training, some of those mechanisms like that it's really hindered us. And so even some of the monitoring there right now. So while we have, for example, that macro level that I was discussing there, some of our capacity is greatly diminished because right now while we're providing that connectivity for it, right now there's not a lot of funds for that type of engagement for us to support those that are at community. And so that is one of I think the challenges that's being faced there, as well as connecting them together with one another, convening power, those types of things like that, that is hurting there as it relates to for us, building on some people are kind of operating in isolation and ad hoc, connectivity.
Thank you, Reverend Troy. Would either of the other speakers, Dr. Charsey or Dr. Nicholas or Joseph, like to add anything?
Yeah, I can actually will concur with Reverend Troy. So one of the biggest challenges our organizations are facing is funding, right? And that makes sense, right? Because we've been talking about this since last year, since the shutdown of USAID. And we know a lot of our partner organizations were directly impacted. They're still being impacted. But one of the things that we've had to do, and this sort of ties into you mentioned that several of us mentioned like the positive and the change. Change is going to happen, right? So we've had to pivot. These organizations have had to pivot, and we've had to look for opportunities, non-traditional opportunities in terms of going after funding. Last year, when we were at the CCIH annual conference in DC, we talked about this. This topic came up a lot. And I remember towards the end, there were presenters that were talking about sort of what we needed to do, new perspectives on thinking about funding. And one of those speakers, I can't remember his name, but talked about how we can't just continue to go after like any and everything, right? We have to specifically focus on, and this is what we've been working with our partners. We have to specifically focus on what are our pivotal areas? What's the area that we work in? Sometimes we seek funding because it's out there, right? And then we try to change our programs to match that. And that again ties back to what I began with the organizations having local ownership, right? When they own the programs, they can actually sustain those programs. But when funders own the program, then they do what the funders want. And so we have to think differently about where we're going after funding and remain true to what we do in terms of our programs and let that speak as the evidence to find new funding and non-traditional ways of funding. And that can happen. That's the positive change in this. Thank you.
Thank you, Dr. Charsey. Yes, that's inspiring. Dr. Nicholas, or Joseph, I was wondering, you mentioned some of your challenges, the displacement of working aged youth, the cost of the cold chain and reliable energy. Are there ways that you have addressed or overcome some of those challenges?
Oui, merci beaucoup. Il est, comme je l'ai dit déjà en passant, les challenges sont nombreux. Je l'ai dit, ils sont nombreux pour que les services de santé communautaire et de l'Église puissent être durables. Il faut en tout cas que le système de financement soit aussi conséquent, que le système soit conséquent parce que c'est un problème de financement de services de santé. La population a une difficulté d'accéder aux services par manque d'argent. C'est un problème qui est existentiel. Et cela revient à la responsabilité à des niveaux du gouvernement, mais aussi de la mobilisation des leaders, de quoi? Des animateurs des églises pour mettre en place des mécanismes de soutien de services de santé pour qu'ils soient durables. Ça veut dire, par exemple, si on met en place des systèmes de mutualisation des soins, ce que nous appelons ici des mutuelles de santé, cela c'est une des solutions qui peuvent aider. Ça c'est un. Avoir aussi des infrastructures qui sont adéquates. Il y a dans beaucoup d'endroits, dans beaucoup de services où les bâtiments sont vétustes, ils ne sont pas de bonne qualité, ils ne répondent même pas aux normes. Mais au moins, le prestataire, il administre les soins, bon, en s'adaptant. Mais pour que le service de l'Église soit durable, soit de bonne qualité, il est souhaitable que l'amélioration des conditions de service soit et que ça soit adapté aux normes pour que les soins soient aussi de qualité. C'est de la même manière aussi pour les équipements. Cela, c'est très catastrophique, c'est difficile de le dire. Il y a vraiment insuffisance d'équipements de bonne qualité. Les médicaments de la même manière. Nous ne pouvons pas ne pas en parler, mais ce sont des défis, des challenges auxquels nous faisons face. Mais avec le peu de moyens, l'engagement de tout le monde, la communauté, nous essayons de maintenir le service afin que pour assurer la santé de la population. Mais pour que tout cela soit durable, soit maintenu le plus longtemps et de bonne qualité, ce que j'ai dit. En tout cas, si les services ne sont financés en conséquence, ça peut être une solution, mais aussi avoir des équipements de bonne qualité et adaptés au contexte qui est le nôtre. Le grand problème auquel on ne sait pas faire face, ce qui est politique, c'est que l'insécurité qui est courant, là, nous ne savons pas faire face parce que ce n'est pas, nous subissons, mais au moins, nous essayons de nous adapter aux conditions telles que ils sont aujourd'hui. Merci.
Thank you, Joseph. Thank you for sharing so honestly, but also thank you for sharing some creative and positive solutions that you all have come up with. And I'd invite anyone who's on the forum today to join in the chat or unmute yourself, come off mute, and share things that your organization's challenges you're facing or solutions you've come up with. I do see some questions in the chat now from Marion. How were the communities in Haiti able to continue? Oh, that's for me, Marion. Okay. So we did leadership and capacity building with them and management building. So each community kind of selected different people, the people that they wanted to be in the leadership and management positions in the clinics. And each of the communities, interestingly, had people knowledgeable in healthcare, like one nurse or one doctor or something like that. And they were able to connect and network with their own church partners as well as the government of health to get the supplies that they needed. And then the people, I believe they had patients start paying a small amount to be seen, but they did not turn people away if they could not pay it. So they started with community involvement and investment and then reached out to their partner networks. Thanks for that question. Okay, Faith, how do you ensure indicator definitions are standardized across different projects and countries? I believe either Troy or Charsey had mentioned the indicators and standardization. Would one of you like to answer that question? Reverend Troy's coming off mute.
Oh, I'm sorry. What was the question again? Because I saw another one up here. I was writing something
Oh,
down
sure.
for, but yes.
Uh, how do you ensure indicator definitions are standardized across different projects and countries?
Right. Well, that's kind of our role with regards to coordinating that. And basically, the main have been working mainly in Zambia, although we looking to, expanding out. But part of it is that, we have in terms of like a guidelines or what have you like that are kind of standardized. And so when we go and give those guidelines and they're training the materials, the forms, those types of things like that, that we have done to standardize this with partners, for on the financial reporting, program reporting, case management, all those types of systems like that that were kind of, some of it was instigated, through USG and, it made those quite useful. Some of these have been M&E tools that have been very useful for programs, that type of thing like that. So if that is answering that part of the question, in some ways, I'm not sure if there's something else that was looking at for that.
I think that's a great answer. Thank you. Um, okay, another question is any recommendations on making community level training, both content and process, more appropriate to retain community level workers? So I will just put a plug in here for CCIH has a lot of different training materials and adapts them for different communities, as well as
Reunião ya formação leo haianza kumbe seze, ah?
I work also with the Global Chain Network, Community Health Evangelism Network, and they have a lot of training materials too. But I'm wondering, Dr. Charsey, do you have advice for making community level training more appropriate or at the level of the community?
Yeah, so that's an interesting question because part of my background is monitoring and evaluation. But what I would say is first of all, we have to make sure that we have both. We have to have content and process, right? Because otherwise, we miss the mark. And so one of the things that I think can be helpful is really being able to understand the community, the community language, right? So being able to understand because we run into this problem sometimes, sort of what we're talking about can get lost in translation. And so when you're able to understand the language and not just the language, but the nuances, right? So when you're talking about combining something like process and content, right, you have to understand both the language and the nuances of what that is. And I think that can be like making sure that that bridge is crossed can go a long way in helping to ensure that that your workers on the ground sort of get it, understand it, and embrace it. So I hope that's helpful.
Yeah, thanks, Dr. Charsey. Uh, And I have another question for Dr. Joseph from the chat. This is from someone in Nepal, but it seems to happen in many other countries too, that the males are out of the country or unavailable. There's limited opportunities for livelihood. Women are overwhelmed with maintaining daily life. In that kind of a setting, how can we sustain community health development programs? Joseph or Dr. Nicholas, would you have an answer to that?
No,
Okay,
I
or
think
Reverend
no.
Troy, Dr. Charsey,
If I
or
don't know if
anyone
Dr.
actually.
Nicolas,
Oh.
yes.
Reverend Troy, Dr. Charsey, anyone else? This is a members forum we can discuss together.
Yeah, I'm not sure I have an answer for that. And I'd rather not have an answer than to try to just provide something just for the sake of providing something.
Yeah, thanks, Dr. Charsey.
Oh, okay. I'm sorry. I was, like I said, there was a question up here out of South Africa. And I was actually typing some things and thinking through that. So I'm sorry. The question again, I hate to ask that again. I'm sorry.
Oh, no worries. The question is, in settings where males have to leave for work, there's limited livelihood, or males are away for some other reason, and women are taking care of children in daily life. So things are overwhelming. How can we sustain community health development programs?
Okay. Oh, that is the question. I think that
Yeah.
as I was looking at that, but talking about that before, and again, this probably requires some others with experience coming in and doing that, and who have the expertise. For example, we talked about community savings groups, and so those aren't very demanding, and with that, small business training, such that mothers or what have you like that, if they're making peanut butter, let's say they're doing, they are using a fork to do whatever. I don't make peanut butter. I'm just giving this example, using it as a fork, but then as they get to with the community savings groups, then they take small loans out of that. So instead of using that fork and they could make so much, they may get $3 to get a machine that could do it much more efficiently. Therefore, they could sell more and then begin working up that way. And that's something that they can do, those who are at home can do for their homes. But part of it is that's one of those issues there, and that can go on up into business. But it's like having a ladder that the first 10 rungs are missing. Once you get up to the 10th rung, you can start going up that way. But the challenge with that, again, where we're missing, what part of the pieces that we're missing and part of that mortar funding, I was calling it, being able to get to those areas and offer and bring that training to the people, along these lines. And so that's the challenge there. So, there are things like that can be done at that level where those who are caregivers and, working or what have you like that, we're thinking about getting some income that way and even extending out to cooperatives and even larger things like that. But that's something there that CCIH, maybe you could talk to some type of foundation or something like that as it relates to growing those IGAs out to cooperatives to seeing about leveraging this into development, along those lines that can bring about income.
Thanks, Robin Troy. And I do think that CCIH, as well as some of the member organizations of CCIH, work with things like cooperatives and small grants and community-based kind of funding things. So that is an awesome answer. Um, yeah. I'm wondering if you said you were typing up some answers to other questions. Would you like to address any of them?
I can do that. I'm talking a lot, so I'll try to be more succinct. Let me go up here to where the one was at here. There's a Richard here from South Africa that was earlier on here. I saw something where that's at. If you see it or anyone else sees it, let me know if you can find that here about yeah, scrolling through the chat here.
And some on training and appropriate materials, uh, professionalization of community health workers and
Oh,
their need to be linked to the health system.
here it is at 9:43, I think, in terms of their. Do you want me to go ahead and read the question, or do you want to read it, or?
Sure, yes, thank you.
Oh, I'm sorry, what did you say? Oh,
Oh, go ahead and read the question.
okay.
Thanks.
Okay, we work with churches in South Africa, specifically around the first 1,000 days of life. What have been some of your insights, challenges, fruit in reaching church leaders to catch a new vision and not be in the me perspective you mentioned? And one of the things I've been working on, and I hope to be putting this out as it relates to this biblical theology, that as we were saying, working with pastors and church leaders, tying this into how is it that they can, that this is part of the responsibility of their job. And one of the pieces that we've dealt with here that I've been going out and the pilot and been working very well with some of the churches is oftentimes we think in terms of things, this thing, that thing, making a decision. Well, we look at, well, that's best for right now. But one of the pieces I go back to and looking at this is going back to Genesis and looking at the creation. A lot of times, what did God make? And we think in terms of things. He made the sun, moon, stars, chickens, goats, sharks, all that. And one of the things I point out there, I asked, in this session there, I'll be short. What did God make on the eighth day? After he rested, what did he come back on the eighth day? Did he say, I need more cows, I need more sun, I need more stars for light, I need this, need this or what have you like that? Is that what happened? And so I started out asking what he do on the eighth day. Well, no, what he created were the cows would reproduce themselves, and photosynthesis and light. And did he need to make more oxygen? No, he made systems. And so that's the part there that I talk about with regards to the aspect about thinking in terms of systems. And then I contrast as it relates to when we think in terms of things, we're not thinking long term sustainably. But what's happening is that what we see there, I think, as it relates to a stewardship, that God wants us to think in terms of things, how these pieces fit together, and to be sustainable and thinking in terms of things. So I relate it to what good leadership is versus poor leadership. And one of the situations I point out, just real life illustrations there, for example, there that people get these houses, and the examples in Africa where people got the houses, got the land, but 6 months later is in shambles because we're not thinking in terms of things. And so that's the aspect there that as it relates to, and also aspects of leadership. Leadership is service. So how do I build up other people to be role players in this, to work together, not serving me, but serving the cause and all of us pushing in the same direction. So that's the part there that this whole model of leadership and then the results that come from that type of leadership versus what we've been doing in the past. And so that part of it is as it relates to this Christ-like example there that with regards to part of what he is looking at, how is he equipping others? How are we equipping others and complimenting others, not complimenting ourselves, and how all are better off if we compliment one another and not just looking at things for ourselves. So that is in short answer. There's some extended pieces, a lot of work that we've done on this that we've seen quite a bit of success with that we hope to be, watching out for, if that makes any sense in any of that I was just speaking about.
That is beautiful and quite transformational, Reverend Troy. Thank you. It's so rich to have healthcare, science, and theology minds on this call. So thank you all. Let's see. Great answer. Appreciate the answers. Okay, we had a question about, here's a question. Example of best practices to mitigate. Okay. When we talk on community group and practice of saving or creating saving fund in the group, there is the practice of taking an unplanned loan by a member of the fund, and finally it creates a risk for sustained group. Do you have any examples of best practices to mitigate these types of risks? So risks when we're talking about community group funding, that a member of the group may take unplanned loans. What I've seen is that the group itself kind of regulates that. They kind of set the ground rules, and there may be a little shame involved if you do something like that, so you don't. But I'm curious as to what anyone who's worked with loans, community loans, group funding, how do you mitigate risks? That seems to be a hot topic today, the community cooperatives. Any thoughts from our speakers or from any of our participants on that one?
I'll just say quickly, I think one of the pieces there that's absolutely critical is the that the groups that come together, that the groups self-select, those people who are going to be participants. And so what's happening is that, those people that they have a relationship, those that they trust, so that aspect of character, good name, that type of thing, it has this reward as a relation, for the people in the groups. Trying to put together groups just like, everyone here, one through, count, say 1 through 4 and just put the groups together that way. That could be, pretty much catastrophic as it relates to that way. And then like what you're saying there, kind of the peer groups, the peer pressure, that type of thing like that, as it relates to, casting the vision for them for what we're about doing. And, that mindset change there, then setting up the criteria for even as it relates to choosing groups, what criteria do we want to look at? It's not just, that one has needs, so let them go ahead and join. But the criteria that we're looking at for long-term success and letting them know that and those guidelines there, giving that ahead of time, even as they self-select.
Thanks, Reverend Troy. I see 2 hands up. I'm going to take them in order. Doug raised his hand first, and then Joseph.
Yeah, thanks. I really appreciate the conversation and all of the speaker inputs. This thing about community investment models, and we've been reading a lot about the role of SACCOs, right? The savings and credit cooperative organizations. and how they are interfacing now with healthcare, especially health facilities. The SACOs that are that have been established around health facilities have really helped smooth out some of the cash flow problems. And they can offer basically a finance structure that the hospitals, health facilities should ideally be able to pay back to. Risk is one of the biggest problems, though. And what happens if the hospital defaults on that? What happens if the community defaults? I would love to see what organizations are doing to balance that risk. So if anybody has really current information about that risk mitigation, that would be really good. But we keep talking about these credit cooperatives and how they can transform community-based and facility-based healthcare. We could talk more about that. I just would love more examples of that. So thanks, Laura.
It sounds like a good topic for another member forum.
Indeed.
So we have just under 10 minutes left, and we need to do our poll and do some closing things. So I'm going to ask Joseph to share what he has to share, and then we will move on. Joseph.
Ok, merci beaucoup. Je voulais aussi parler un peu sur la question de ce que nous appelons ici des associations d'épargne villageoise qui s'inscrit dans cet aspect de donner, de faire une synergie de ressources au niveau du niveau communautaire. Donc, le membre de la communauté se met ensemble pour essayer de créer des caisses d'épargne, comme le cas de la question de l'aspect qui a été évoqué ici. Cela permet aux membres de se soutenir mutuellement pour avoir de l'argent pour payer les services de santé. Bon, visiblement, ces initiatives, elles sont bonnes et pour certains, ça leur permet de constituer des capitales et créer des business qui sont pérennes, des business qui durent longtemps et il leur permet de quitter le stade vraiment de manquer les ressources pour le payer, les services et subvenir à d'autres besoins. Mais aussi pour certains d'autres, c'est difficile parce que ce sont les seules ressources qu'ils ont. Ça fait que les moyens, les ressources qu'ils ont pris dans l'association là d'épargne, ils essaient de commencer des petits business qui deviennent le seul source de revenus. Après un temps, les sources de business-là tombent en faillite et les personnes reviennent dans la situation du départ. Pour dire que ça paraît comme ce que nous appelons un cercle vicieux. Après un temps, la personne revient dans la même situation. Et ça arrive qu'une telle personne peut prendre une grosse somme, comme l'exemple ici. Il a pris une grosse somme avec l'objectif de vraiment faire un beau business, mais vu les attentes qu'a la famille sur ce business, ça tombe en défaillance, mais il n'arrive plus à rembourser tout cet argent parce que c'est un prêt qu'on lui a donné. Et ceci déstabilise souvent la continuité de ces associations d'épargne et ça crée d'ailleurs souvent des conflits et d'autres des arrestations. Nous en connaissons des exemples, des cas. Mais au niveau communautaire, ce sont quand même des bonnes initiatives. Ça permet aux membres communautaires de trouver des solutions aux problèmes de leur santé, financer les activités. Mais le gap là, c'est que le problème est que quand ça devient la seule source et que tout doit venir de là, ça tombe vraiment par la suite en défaillance et on se retrouve dans la difficulté de rembourser, la difficulté même d'autres dettes qui ont été prises pour essayer de combler à gauche, à droite. Bon, peut-être que des études peuvent être menées aussi là-dessus pour voir comment y contourner, comment on peut gérer de telles situations euh, pour que des solutions durables puissent être trouvées. Merci.
Thank you, Joseph. Yes, that was a great outline of the issues, as well as noting that not every solution will work for every community. So it's so great to have a forum like this to hear lots of different ideas and solutions that may work for ours. So as we near the end, we want to repeat our poll, the poll that we did at the beginning, and see if we improved in our knowledge of community-based programs and sustainability. So we'll pull the poll up for you to answer, see if we're feeling more comfortable with community-based programs after what we've talked about today. I think we are leaving today with lots of ideas for solutions, as well as lots of questions that we can even continue connecting outside of this forum. But the poll is up right now. If you would all take a minute to answer that again, and we'll see how it changed. And thank you all for your participation. I apologize for any questions that we did not get to today. Please feel free to reach out to CCIH or me with any of those questions, or each other, connect with each other, and form some more networks and more partners for your organizations. I'd also like to encourage you to identify an area of your program to review in light of what has been discussed today. And we will wait a minute and see the answer of our poll, and then I have a special invitation for all of you. Okay. I think we have changed quite a bit. I think our highest level at the beginning was moderate, that had the most answers, and now good has the most. 56% of us feel good, and 28% feel very good. So that is awesome. Thank you all for your participation and for coming and joining us today. And now for our invitation. CCIH will hold a virtual learning institute at the end of September. So we're coming to the end of our forum, but not the end of our learning. CCIH will hold a virtual learning institute at the end of September to help faith-based organizations tell their stories, to build support and grow their impact. More themes that we discussed today: telling our stories, building our support. So Molly is putting a link to more information in the chat for the Virtual Learning Institute in September. Thank you all for your comments in the chat also, and for sharing your experiences. Okay, so I think yes, the CCIH Virtual Learning Institute link is in the chat. And with that, I will close us with saying, go forward sustainably, everyone. Thank you for being here today.
Thanks, everyone.
Thank you all.
Thank you. Thank you, Laura. Thanks all.
I also
Thank you
just
very
want to
much.
say
So
this
much.
CCIH announced their conference dates for 2027, June 21st to the 24th in Kenya next year. The call for abstracts have gone out. We hope you submit abstracts to everyone. So hope to see you at all the different CCIH things, but good to see everyone's faces, and thanks for the engagement.